Hello, this is Rachael Babin and welcome to the Oncology Podcast, brought to you by oncologynews.com.au. Today we have a very timely episode. I'm discussing how we can make telehealth human with Dr. Ursula Sansom-Daly and Dr. Natalie Bradford. Ursula, as some of you will know from her commentary pieces for oncologynews.com.au, is a clinical psychologist for the Sydney Youth Cancer Service, the leading clinical team for the treatment and care of adolescents and young adults aged 15 to 25 with cancer in Sydney. She is also Senior Research Fellow and Deputy Head of the Behavioural Sciences Unit at the School of Women's and Children's Health at the University of New South Wales. Natalie is a Queensland University of Technology Senior Research Fellow based at the Queensland Centre for Children's Health Research. She has a clinical nursing background in paediatric oncology and palliative care. Hello to you both. Thank you so much for taking the time to chat with me today.
Thanks so much for having us.
Yeah, hello. Lovely to join you.
We usually start with a more personal question so the listeners can get to know you a little bit better. So I'd like to start by asking you, Ursula, how you found yourself working as a clinical psychologist supporting AYA patients with cancer, and what personally motivates your research activities?
Yeah, that's an interesting question. And I think for me, it's a case of many different winding paths ultimately leading me to the same place. So one key thing for me was when I was much younger, actually, I had the experience of being diagnosed with a brain tumour myself. And that really opened my eyes to the experience of what it is to be young and to be sick and to be suddenly thrust into a hospital environment. But I've always had a passion for clinical psychology. And many years later, trained as a clinical psychologist and, was able to get a job where I was able to work with young people. And I just love working with young people because they're this group that have this great resilience and great potential, but they also can have these unique risks. But I think if you can make change for a young person at that point in their lives, that could affect the whole trajectory of where they go from there. So that's really exciting to me. And that's really what motivates me in my research as well, is to say, being a clinician researcher, to see how we can kind of actively, look at evidence-based solutions to improve how clinical practice happens on the ground. So that's kind of what I love to do and what keeps me motivated.
Fantastic. Thank you. And a fairly unique perspective as a childhood survivor. It's an incredible story. Thank you for sharing that with us. And over to you, Natalie, if you could tell us a bit more about your background and motivation to support young patients, particularly in the palliative care setting.
Yeah, so I always wanted to be a nurse. I grew up wanting to be a nurse without really knowing what that meant. And then fairly early in my career realised I was really no good with blood or trauma or anything that was too gory. And for that reason really went to sort of medical care and cancer care sort of early in my career. I ended up in paediatric oncology in my very, very early 20s, and I suppose was really struck by the harrowing situation that families, found themselves in with when a child's diagnosed. It's such a traumatic time. And being based in Queensland, we're an enormous state. There was huge upheaval for families when they had to relocate for treatment. Any family that's living outside of Metro Brisbane, had to come down for treatment. They might be 2,000 kilometres away from home, and they would need to come for sometimes up to 12 months. And that, I suppose, is what really sparked my interest in telehealth. And just, as technology advanced over the years, could we do some of what we did routinely in the clinic and in the hospital? Could we actually do that in people's homes? And certainly in the palliative care setting, when we were, we had families who desperately wanted to be able to care for their child in the home setting, especially when they'd spent so much time in hospital receiving treatment. And when there were times where cure wasn't going to be possible and families had that precious time, they really wanted to be able to spend as much of that at home. And so we were really interested in seeing how we could use telehealth to support families in that space. And that was really the basis of my PhD work.
Fantastic. Thank you for sharing. And I'm so glad you could both be available to chat today. So let's start, if you don't mind, for the broader audience, and we'll talk briefly about what we mean when we say telehealth and teleoncology.
I mean, I think here we're really talking about any time we're delivering clinical services remotely using some kind of telecommunication services. So in the old days that could, include, and it could still include the plain old telephone, as a form of telehealth. But these days, primarily what we are talking about is sort of the online video conferencing. So like a clinical Zoom where you're kind of seeing and hearing each other at the same time. So it's a live connection. It's a synchronous connection. You're there at the same time in real time. And so, we could talk about teleoncology being how we deliver oncology services using those methods. And we can also talk about tele-mental health. So it's kind of almost more of a methodology than a particular discipline. And it's very adaptable.
I suppose it also is that exchange of information, so a two-way exchange of both information on which then a clinical decision can be made. And without that exchange, without that sort of ability to share information.
Great, thank you. Most of us are becoming much more aware of and using telehealth services more because of the COVID-19 pandemic. So it would be good to explore this aspect. Has COVID accelerated how much work you're doing in telehealth? And is this a good thing?
I know certainly in the hospital where I'm based, it has rapidly accelerated, and we are, I've been undertaking research in the telehealth space for about 10 years now, and that's really been thrown out the window. What's been, I suppose, achieved in terms of moving clinics to the online space in the last 4 months, has really wiped out 10 years of research, which has been amazing to see that adoption of telehealth. And it's been very necessary. It's providing a way to continue providing a service while keeping the safety of clinicians and patients in mind. So we've seen a rapid change, and a lot of our outpatient services are now all being delivered by telehealth. And then we're also more routinely dialing into other regional centres. And certainly oncologists are saying maybe we could have been doing this a little bit more, and maybe we should keep some of this up when things do settle down. It's really about finding that balance and thinking about when is it appropriate and what types of services should we be routinely offering via telehealth.
Absolutely. And I'd like to get into the detail of that a little bit later. How about you, Ursula? How have things been going in your clinic?
Yeah, I mean, like Natalie, COVID-19 just pushed us all to very suddenly and rapidly be using telehealth in a range of applications and settings where it wasn't being routinely used before. I've been using telehealth in sort of clinical programs that were sort of integrated or embedded within research studies for possibly a similar time to Natalie, about the past sort of 5 to 10 years. And then also because I was quite familiar with it already. I was already using it to some extent in my clinical practice. So for me, it wasn't as big of a shift, but certainly I was witness to that mass shift and mass adoption that took place in the hospital. And I think it is certainly still ongoing. And I think in my centre in Sydney, some of the initial worry around COVID-19 has to some extent died down, but then at the same time, we are still continuing to have a lot of outpatient services delivered using telehealth, and also meetings. So large multidisciplinary meetings where we might used to have had in the past, maybe 30 different health professionals crammed into the one room. We're now meeting, over telehealth or, video conferencing to be able to achieve that at the same time, with social distancing.
Fantastic. And do you think you'll be able to ensure the momentum of this new effort when it comes to telehealth once hopefully, we flatten the curve and we get past this pandemic?
I hope so. And look, I hope that one of the things that will come out of this is that people prove to themselves and to their patients and as a system and as teams that we can do it and it can work. I don't think it's all necessarily been smooth sailing. And I think, overhearing colleagues, I know that some of the online systems haven't always coped with the burden of us all suddenly using the online video conferencing at the same time. So I think we need to think about what those barriers are going to be to keep it sustainable in the long term. So we've got to address those kind of logistical, technical barriers, make sure that the systems are there to support it. For our colleagues who aren't based at hospitals, we need to think about, ensuring that the financial reimbursement and Medicare systems are ensuring that it's financially viable for them to continue offering telehealth as well. I'm hoping, and I think, in the piece that we recently wrote, I think we were hoping that perhaps the COVID experience could also help us get over some of the kind of almost psychological barriers that we can have as clinicians to telehealth. I think there's been a lot of fear and apprehension about it in the past, and hopefully just through sheer exposure during this pandemic, that might be something that we can move a little bit past.
We may have reached the tipping point. Yes, thank you. Yes, it's really good to talk about those barriers that are in place for some people. And I remember at the beginning of the pandemic, we did an interview with Eva Segalov on COVID, and she was talking about, her patients weren't a problem at all during the transition to telehealth, but having lots of patience was really, really important for the team because they were learning new systems, and it can be quite stressful, particularly in an already stressful circumstance. I think we all feel like we're Zoom experts now, but perhaps some are a bit more reluctant than others. What sort of reservations have you come across that healthcare professionals talk about having typically?
I think people don't even necessarily realise themselves just some of the barriers that are there. And you see it quite often. People don't like seeing themselves on camera for a start. And you'll see if you've got a few people there, people try to shuffle off to the side so that they're not visible. So there's certainly an issue there with just seeing yourself on camera and what that feels like. We have the technology, and yes, it can be problematic at times, and it can be, have issues with bandwidth and things not working and glitches. So there is a compromise there maybe in the quality of the interaction. And I think that really puts some people off. We're professionals and we like to have control about the way that we're going to communicate, and telehealth or using technology can interrupt that, and the natural flow may not be there for people. And I think that ability to control the way you're going to interact is different for clinicians, and that's something that's difficult to grapple with. So there's both those external factors and then also the internal factors. And I think maybe even just acknowledging that these are there and sort of having some access to training and understanding, that might be a way that we can break down some of the barriers that are there.
Yes, that brings us very nicely actually into discussing the dynamics of power and control in these circumstances. Ursula, perhaps you'd like to come in here and talk us through if there are any ways we can navigate this aspect to make telehealth more human.
Yeah, and I think it's such an interesting part of it. And I think, Natalie hit the nail on the head in the sense that it's not something that we typically voice that much, but I think as health professionals, we are trying to be professional at the same time as obviously trying to be personable and empathic and connect with our patients and all that kind of thing. But there is still that power dynamic. And so I think one of the very basic fears that we don't necessarily always voice, but it's that sense in which of how am I going to kind of still hold the reins if I can't control the fact that the internet's going to blip in and out and be glitchy? How am I going to retain control? How am I going to retain my composure and, control of the clinical session or my ability to kind of guide the clinical session? So I think there can be anxieties around that. When we're thinking about how we can, get the very best out of telehealth and really, adapt it as best as we can into the future, I think we need to be thinking about the positives and the negatives, because it's not all good and it's not all bad. And I think we need to be cognizant of both. So one of the benefits of telehealth that could really be beneficial for our patients and really start to break down this power dynamic and this sort of hierarchy that can exist even without us meaning for it to in the hospital setting is that patients can be connecting with us from their safe space, potentially from their bedroom. So I work with adolescents and young adults, and for them, It can mean that it's maybe less daunting, meeting a clinical psychologist for the first time. They don't have to turn up to a rather drab-looking waiting room where other people might be looking at them. We know there's mental health stigma. It might also mean that they're, potentially even able to consider and integrate what we're discussing, integrate that with the realities of their own lives. So if we're talking about coping strategies, it might make it a bit more real world for them when they're sitting in their bedroom talking about it, rather than talking about these things in abstract in a hospital clinic room. And, as a clinician and as a psychologist, I've found that there have been wonderful ways to harness that with my young patients. So, for instance, you can ask about that piece of art that they have behind them, or how they've kind of decorated their home space to make that a really safe and comforting space. And it kind of can actually give you these sparks of ideas to connect with a patient that you wouldn't have thought of otherwise. But there are obviously negatives or potential downsides to this as well. So home may not be safe and comfortable for all of our patients. And I've had patients through the COVID-19 pandemic, and this is something we wrote about in our recent clinical reflection, where for them, the home life was the very crux of their problems. And so for them, connecting with me from that home space wasn't necessarily comfortable or safe. And so this is something really practical that we need to be talking with patients about, maybe ahead of the telehealth session, and then also at the start of each session, checking, are you in a safe, confidential, private space? And of course, this can change midway through a session as well. I had patients where, I could hear that a parent arrived home mid-session, and suddenly that changed their demeanour. So, and then thinking about what's their plan, what's their self-care plan after the session takes place as well, because there's no longer that buffer of leaving the hospital and going somewhere else where they might be kind of debriefing and processing the clinical interaction.
Yes, thank you. There's some really good points there. Whilst we're talking about the kind of the nitty-gritty of it, actually, I think perhaps, Natty, this would be a good time if we could talk a bit more about things like eye contact and, non-verbal cues that happen all the time in a face-to-face setting that are much harder to replicate perhaps in a telehealth setting.
Yeah, and they are. The natural flow of communication is interrupted, and we're all sort of told, okay, well, we look at the camera and so, try to maintain eye contact. But in a natural conversation, you actually don't do that throughout the whole conversation. And certainly in a clinical interaction, you would be looking at, some different results, or maybe an examination, or a variety of different things, and you're not actually just staring at the person's face the whole time. So to actually maintain eye contact with a camera feels very unnatural, and it creates a barrier there that I think, do we really have to look at the camera the whole time? Is there a better way? And look, I'm sure with technology changes that some of that we will find that moving. But there's not only, I suppose, just that eye contact, it's also just the idea of, well, who's running the consultation? And so, Ursula's description there of being in the patient's home and in their bedroom, that's a very personal space for that patient. And so I wonder in that context, who's in charge of the consultation? We've been invited into our patient's home. It's not the same as a patient coming and visiting you at the hospital where they're really told what to do. They come into the waiting room and you show them the chair to sit on and these sorts of things. In somebody's own bedroom, it's a completely different scenario. So there's that change in power of how the consultation might play out. And I think for some of our clinicians, that's a difficult thing, and they're not quite sure what their role is in that. So I think there's some of the things that we need to really unpack and learn a little bit more about. What are the ways that we can really support communication in these types of interactions?
Yeah, and I would add to that, I personally kind of like that because I work with young people and I try to adopt quite a collaborative approach to how I set up my sessions. And so I kind of like that the telehealth levels the playing field, so to speak, and it kind of opens up, that we're potentially all part of shaping how this clinical interaction takes place. But I do think that what comes with that is potentially a need for us to be thinking and talking more about our ways of working, how we set up sessions, and having those, maybe making it explicit in how we talk about patients, about how clinical interactions are going to take place and what they're finding useful or comfortable or otherwise. One other thing that I was thinking as well, with this idea of kind of connecting with patients in their safe sort of home environment, or, what we hope is a safe, home environment for most people, is that I think that means that we do need to be thinking about what that clinical session is going to involve. And I think this leads us into a bit of a discussion, which I'm sure we'll have later, about who's right for telehealth, or what patients, we should or shouldn't be doing telehealth with. We know from psychology and psychological research that whenever we're having some kind of learning experience or vivid emotional experience, we kind of encode or kind of remember the environment where we learnt that information in or had that experience in. And we know this clinically from all of our patients telling us about all of the different reminders around the hospital that remind them about different kind of really key events that happen through their cancer treatment. So I think as clinicians, we need to be really thinking about, what conversation are we going to be having in this clinical interaction today? Are we going to be talking about bad news? Are we going to be talking about potentially some quite sobering or scary, long-term late effects that might come from this treatment, or things like that could be potentially distressing? Because there's things we need to think about managing, the safety and the distress of the patient and the family during the session. But then we also need to be cognizant of the fact that perhaps after that telehealth session, perhaps that patient, every time they look up at their kitchen clock for a little while, is going to have a jolt of a reminder about that information. And, this isn't necessarily a reason not to use telehealth, but it is just something that we need to be aware of on the human factors level. And that's not necessarily a bad thing as well. Maybe we're going to be talking with our patients about how they can be integrating exercise or healthy eating into their lives. And if they're having that session whilst they're sitting at their kitchen table, maybe that information is going to sink in a different way that it would in the clinic room. So again, there's no hard and fast or black and white here, but I think they're really interesting human factors to be thinking about.
Yes, exactly. Human factors. Everybody is different, and everyone's circumstances are different. I hadn't actually thought about things like, delivering positive information around healthy eating into someone's kitchen. And I think that could be powerful compared to, being given a leaflet in a doctor's office. So what do we think patients feel about telehealth? Do they like it?
Some of the work that I've done, we did an interesting study where we went out and didn't sort of go out looking for people who had experienced telehealth, because generally if you ask a patient, they'll usually say, oh, yes, they're satisfied with good care, and they can also be satisfied with, a fairly, substandard interaction as well, because they've received some level of service. We went out into the community and we were asking, just what the general public thought about telehealth. And it was quite surprising how few people were really aware of really what it meant and what we were talking about when we were talking about telehealth. People seemed to think, it was some way of, maybe prescribing medicine or, a way for collecting, different bits of information, but not really thinking that it was an actual interaction with the clinician. So I think we need to do a lot more work around just that communication and promotion about what telehealth is. And I suppose through COVID, we have seen that happening. There's a lot more exposure, I suppose, and we're seeing more and more patients receiving these types of services. So I think it'll be really interesting to just see the type of work that comes out from this experience, and asking patients and perhaps giving them a choice, giving them the ability to maybe choose whether some interactions may occur via telehealth, instead of us always assuming that we are going to have an interaction in a particular way.
And is that something that you find, Ursula, you already were doing quite a lot of your practice using telehealth anyway, so presumably your patient cohort is quite open to telehealth?
Yeah. And so, with the group I work with, adolescents and young adults, they are pretty open, I would say, on the whole to telehealth. And certainly, pre-COVID work that I've done, we've shown really good acceptability and feasibility of using telehealth, whether that's, individual level psychological sessions or, group level interventions. So some of the work I've done has been developing a group psychological intervention with online video conferencing, and we've found really good engagement. So in one study, we showed that about 98% of all the young people who participated in those online groups stayed engaged. So, they really found it a useful way to be engaged. And they also interestingly, they rated the connection that they had with the group and also the connection they had with the psychologist facilitators really highly throughout that intervention. The interesting thing was that the psychologist facilitators seemed to be a little bit more hesitant, and their sort of comfort with the modality seemed to increase over time, which I think starts to hint at those disparities between patients' readiness and clinicians. I guess one thing I would say as a caveat, and this is a point that we make in our recent commentary piece, is that you can't assume with any cohort. And so even though I work with young people, they get labelled as digital natives all the time. They are quite open, but you can't assume. And so even, one of the most interesting things that I've found with my patient cohort through COVID-19 is that it's been quite variable. The vast majority of them were quite happy to transition to telehealth appointments in the peak of lockdown and things like that. But then, there was variability in those preferences, and several of them have since kind of preferred to transition back to face-to-face now that lockdown has eased a little bit. So there's kind of a bit of a movement both ways. But I think if we're talking about patient-centred care for any cohort in oncology, patient-centred care, part of that is giving them those choices.
Yes, absolutely, because it's not going to work for everyone. And I think this is a good point to get into some details on who telehealth suits and which patients, you don't recommend telehealth for.
I think, certainly for, probably for our patients who come from culturally and linguistically diverse areas, we've really got to be aware of language barriers. And if we're putting, telehealth does interfere with some aspects of communication, how important, if English isn't somebody's first language, we need to be quite sure that they are understanding the context. And certainly for our First Nations people, I know a lot of times when I've been doing some work with them, there is that tendency to say yes, did you understand what I was explaining? Yes. But some of that can just be, there can really be a disconnect there between actually understanding a message or not. So I think we need to be very careful about anyone where English might not be their first language or where there might be some of those cultural differences, that we can't just assume that clinical practice is going to be transferable across telehealth. I think then also, as Ursula was alluding to, any of those patients who are vulnerable, who maybe have complex family dynamics, or, where there is the disease is unstable and, if there's progression to palliative care, we need to be thinking very carefully about when it's appropriate to provide information via telehealth, or when we really should be thinking a little bit more carefully about the context. And as Ursula was alluding to, when and how and where we convey information is just as important as what that information is. So we need to be cognizant of all of that and really think through some of those aspects.
Yeah, and if I can add to that, I think that one of the hesitations that I perceive on the part of clinicians in using telehealth pre-COVID was, I think, a lack of certainty around also how to do it safely and appropriately. One of the pieces of work that I led with my team a couple of years ago was actually looking at, clinical practice guidelines and ethical frameworks that existed worldwide. We're thinking, what are international bodies saying about how we should be doing this appropriately and safely and things like that? And it was really interesting to get into the nitty-gritty, because there were 19 guidelines that we ended up including. They all said quite different things, which is the first interesting thing. There wasn't, a lot of perfect overlap between them. And the vulnerable groups was a real gap. So out of the 19 guidelines that we looked at, only 6 of them specifically addressed anything to do with children and adolescents and minors. And only one of the guidelines specifically talked about vulnerable illness populations or unwell, hospitalised, groups. And that's interesting, because they're groups that really could benefit from telehealth for a range of different reasons, but you need to have those sort of specific, you need to tailor your practice, I suppose, to suit and to be appropriate. In the work that I've done, we've kind of been thinking from the mental health lens, how do we do it safely from a mental health safety perspective? And so in some of the work that we did evaluating that group online intervention, the Recapture Life trial, we kind of specifically looked at that and looked at, any kind of clinically concerning events that came up in terms of participants being distressed, suicidal, anything like that happened across the course of the trial. And really encouragingly, what we were able to find was that we were able to detect the vast majority of those things and manage it all really well, even though we were only having contact with these patients using telehealth. So I think there's certainly ways that this can be done well and appropriately, but it does require a bit of forethought. And one of the things that I would love to see come out of COVID is actually our professional bodies do a bit of work to kind of bridge the gap between the sort of abstract level kind of best practice guidance and actually what does that look like on the ground? Like, how do we operationalize that for the average psychologist, the average social worker, clinical nurse consultant, doing this on the ground, like very practical guidance? That would be great to see.
Yeah, I agree. I think that's so needed. And, and that because we're not saying that we shouldn't be providing telehealth services to these groups of people, but we need to take that extra care and thought and consideration when we do. And what does that mean? What practical guidance have we got to really support us in that practice? And so there's definitely some work that needs to be done to bring that together.
What sort of research do you think we need next to advance what we're doing in telehealth and oncology?
Can I start by saying I don't think we need a lot more research into satisfaction with telehealth. I think that has been done over and over and over. I think we need to dig deeper and get down into some of these other issues around just exactly what is that communication barrier? What does that mean and how can we get around that? And looking at, what type of guidelines do we need to support our practitioners? And that's going to go across a range of different specialties. So, different disciplines are going to need, different guidelines. So there's a lot of work to be done in that space. We also need to educate the population, our patients. They also need to be aware of what is and what isn't possible and what services, may be available to them if we're able to work together as a community rather than in these separate silos. So I think we need to dig deeper than what we commonly see in the telehealth literature, which is a lot around, everybody's satisfied. We were able to do it. We were able to see each other and hear each other. And you commonly see these telehealth tools which just ask about, the quality of the video and the quality of the audio and could you understand? And that's not good enough. We need to get deeper than that and really unpack what was going on in that consultation. How did it make people feel? How confident do they feel about managing their health condition after that interaction? Have they really got the information that they need to move forward from both ends?
I'd agree with that 100%. I think the acceptability, the feasibility, we've kind of got really solid evidence for that now, and even efficacy. So, obviously that's a concern if we're delivering clinical interventions. We do want to make sure that we can do so with the same effects. And even I've just been reading a paper coming out in Psycho-Oncology by a team in Barcelona where they've done a pragmatic RCT looking at telehealth versus face-to-face for distressed breast cancer patients, found essentially equivalent efficacy across the arm. So that's really encouraging. I kind of see two gaps, and I think this ties in with what Natalie was already saying. The one piece is implementation. So I think it's not really good enough for us to show that we can do telehealth well within the kind of super controlled bubble of a research study, because really, if we can't actually scale it up into the messy, complicated, multidisciplinary hospital world, then it's just not going to go any further than that. So I think we need to be all kind of working with implementation scientists a little bit more to be collecting process data, collecting data on the barriers and the facilitators and how we can integrate it into our routine practice across all of our telehealth studies to line it up for that kind of future sustainability. And yeah, the experiential piece that Natalie just referred to. So I think we do need to do better at capturing and measuring the patient experience. I think that does involve getting a bit better capturing the things to do with the relational therapeutic relationship, the working relationship. And that's both on the patient side, their sense of engagement and confidence with their healthcare plan and their healthcare team, and also on the health professional side, their perception of the rapport, motivation, understanding. And we need to be able to do that in an ongoing and dynamic way. So I think there's exciting work to come, and it's also slightly more sophisticated and tricky work.
Yes, indeed. Often the case, isn't it? Especially now that we've experienced such a nationwide rollout, worldwide rollout, really, of telehealth services. So thank you both for sharing these great insights with us. It's been a really informative and encouraging discussion, so thank you. Are there any practical tools or tips or, key take-home messages that you'd like to share with our listeners?
I think there's actually a lot of resources out there but they're probably a little bit hidden, and people might not be aware of them. But certainly the RACP have got some really good practical tips and guidelines for around just the general principles of conducting telehealth consultations. There's plenty of literature out there, and we're happy to provide links to different articles. There's systematic reviews on different aspects of telehealth. But I think some of those practical things are really important. Some of the things around, how to, it's the change management processes, not just the technology aspects of it, but really how you go about setting up a telehealth clinic and the things that you need to think about when you're changing some of your practice. So we'll certainly share some of those with you and provide the links.
Fantastic. Thank you. Ursula, was there anything you wanted to mention that you think could be a good practical tool or a resource for clinicians?
Yeah, as a practical tool, I think one really great thing that I would put a plug in for is the Australian Digital Health in Cancer Care Roadmap, which is a pretty recent piece of work led by Professor Bogda Kozwara and Dr. Lisa Beattie and the team in South Australia. And it outlines some really great directions for research and clinical priorities in this space. And that's very much been a piece of work that's been driven by health professionals, but also in partnership with patients and survivors too, which is really critical. But, I think other than that, like Natalie said, there's a lot out there. I would just, want to encourage listeners to ask patients, both, if they're open to it, and then when they're using it, keep asking, how are you finding it? What's working? What's not working? What could we do differently? What could we do better? I think asking about that sort of ways of working process stuff is stuff that we can forget to do as health professionals. Sometimes we perhaps don't do it often enough, but I think it can be so fundamental to care that is tailored to patient needs and responsive to patient needs. I think that can be a nice window to how we can have these conversations about telehealth.
Fantastic. Listeners will, of course, find links to the resources discussed today in the notes on our website. Well, thank you both once again for taking the time to discuss how we can make telehealth human. We really appreciate your time, so thank you. This is Rachael Babin, and you've been listening to the Oncology Podcast.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.